right, this is for the genetic counselors regarding siblings of children with CDG. Has there been a long-term study following the siblings to see if they have children who have CDG? And a second related question is, what's the protocol, if there is such a thing, in terms of genetic counseling for siblings with CDG?
Okay, well, I'll answer the first question. You know, because these conditions are quite rare in the general population, so for most of these diseases we're talking about autosomal recessive inheritance. There are exceptions to that. Talking about James, who has the X-linked form, the ALG13 gene, but most of them are autosomal recessive. The likelihood of a sibling, you're speaking of siblings who we know are carriers of the condition?
Don't know.
Okay. So first of all, we know that the siblings who we know are unaffected have a 2/3 chance of being carriers, right? Because we know they don't have the disease, and then there are three other possibilities. One, that they received the non-mutated gene from each of their parents. And then the other two possibilities are that they either received a mutation from their mother or they received a mutation from their father. So a 2/3 chance that each of those siblings may be carriers, okay? Then if they go on to grow up and have a happy family of their own, the chance that their partner, whoever that might be, is a carrier for that same rare condition is extremely low. So, you know, as we know, these are rare conditions, and so the carrier frequencies are probably pretty hard to even estimate in the population because they're so rare. Ava might have an idea of what some of the numbers are, but they're extremely rare. So if the sibling is having a child with someone who we know is not related, not a distant cousin or anything like that, and the likelihood that they'll have a child who's also affected is extremely low. Okay. As far as long-term studies of carrier siblings, I don't know if Ava might know something about whether that's ever been examined, but we wouldn't expect that they would have symptoms as far as the autosomal recessive conditions are concerned. Do you want to add anything to that?
I think it's a very good question because in some other disorders we discovered that some of the carriers might develop some kind of symptoms. But in the last 20 years following those families, we never encountered any affected carrier or sibling. About the carrier frequency, I don't know it by heart. Actually, it's higher than you would expect, but some of the mutations are so bad that when a child the conception happens with that mutation, many of these children will never make it. And so it's very hard to assess the carrier frequency because many of these children with a very severe mutation will never get born. So usually in our practice, if somebody is in a family who's worrying about a recurrence risk. So for example, a sibling who's healthy but just want to be sure that he's not marrying or she's not marrying another carrier, we would test the carrier before or when they are married.
And you can sequence the partner too. You can sequence their partner just to be on the safe side. Now, genetic testing isn't 100% sensitive. We have to remember that. You know, there are pockets of the genes that are sometimes missed, not because of mistakes, but because the technology is not perfect. We know there are certain areas in the gene that may not be picked up when we do genetic testing. But we can rule out, to the pretty confident extent that, if we have a sibling who's a carrier and they want to have a child with someone else, we want to be absolutely sure that that person is not likely to be a carrier. We can test the partner. So that adds another layer of sort of feeling a little more comfortable that it's not going to happen in the next generation. Yeah.
Also, a good thing to look at is not only the siblings and how they would end up being carriers, but we know that both parents are often carriers, and that there doesn't seem to be an added health risk associated to being a carrier if we look at the parents. There is one feature that is described in carriers, and that is a low cholesterol for the PMM2. No? It's not entirely clear yet, but it looks like the cholesterol in the carriers would be a bit lower, and then in the children that have both mutations that it would be even lower, which is actually a good thing to have low cholesterol. So I think outside that there's nothing in the carriers known.
Yeah. The only other thing I'm going to say about genetics is it's really getting much harder, because we did used to be very clear about autosomal recessive, but there are de novos now, there are sporadic, there are dominant, there are X-linked, and ALG13, we have a cohort of ALG13 females that we follow at NIH that have a very different phenotype than the boys. So I think that we're going to start to see, now that we recognize lots of different inheritance patterns in lots of different things, I think we're going to see a lot more variety than we expected over time.
Thank you. It's for Lynn, actually. You had talked about the disorders you've already looked into. Would you go and do studies on ones you haven't done already?
Oh yeah.
Outside of that list.
Oh yeah. We are always open to seeing anybody that has we're open to seeing anybody that has any type of CDG, or actually we even have seen patients that there was a suspected CDG, like that kiddo you saw with us. So we saw a patient with a hyper IgE syndrome with a really bad ichthyosis that our team thought might be like a PGM3 or maybe a Dolicho disorder, and we ended up finding a totally new disease in a receptor of one of the interleukins that's never been reported before. Totally not a CDG. But the biochemistry suggested that there was a glycosylation abnormality, so it's probably another disorder with a secondary glycosylation abnormality, not a primary CDG. So, so the natural history study says for known or suspected, and we are open to seeing as many different types as we can.
This one is for you. My niece also has the CDG, the PMM2, and this gets a little over my head on all of the wording on this, but they have the same mutations. So would that mean that me and my husband and my sister-in-law and brother-in-law are all 4 carriers of this?
So this is your niece through yours?
Through my husband.
Through your husband's side. Okay. So I'm presuming that, your niece through your husband's side has the same mutation that was found in your husband? Is that correct?
The kids have the same
Okay.
mutation.
Have you and your husband had mutation testing yet?
No.
You have not?
No.
Okay.
And neither have
And your
them.
niece is a carrier?
Niece has.
She has
She
it.
has
Okay,
it.
got it.
So they both have it and both have the same. She explained it as like it's a paragraph. And
Okay.
that when you read this paragraph, you may have like 42 something.
Mm-hmm.
I don't know if I'm making sense.
Yeah, there's a mistake in the language.
Yes.
Right.
So the same words in their paragraphs were
Mhm.
mutated, or the like.
Do you recall if for your child both of the mistakes in the 2 copies of the gene were the exact same change? They were the exact same change. Okay. And in your nieces, were they the exact same change?
Yes.
Okay.
Well, they were the exact same as each other.
Okay.
But neither parents have had the
Right.
testing done.
Right, but this is your sister-in-law is the parent of
Yes.
this. Okay.
And there's no relation.
Sure.
Whatsoever.
Sure, that's really interesting.
I know.
Yeah, so it would not mean, to answer your question, the question was, would that mean that all of the siblings in the SIB shift would also be carriers?
Yeah.
And you're talking about your siblings or your husbands or?
So me and my husband have a child with CDG.
Right.
And then my sister and brother-in-law have a child with
Right.
It's my husband's brother.
Right.
So are we all four carriers, or how rare?
Yes,
is that?
most likely. Most likely. I mean, theoretically, one of the parents could not be affected and one of the copies could be de novo. That's when it is present for the first time in the patient. With recessive diseases, that tends not to be the case though.
Okay.
Statistically, it's more likely that both parents are carriers.
Okay.
So that would be the most likely scenario.
Okay.
Now for each of your siblings and each of your husband's siblings, it's not automatic that they're carriers.
Okay.
It would be probably a 50-50 chance. Most likely one of the grandparents is a carrier as well. So that's the likely scenario there.
This makes sound silly. Does it just come up from somewhere, like on my side of the family and on my husband's side before our generation?
Right.
There's never been any.
That's what can happen with recessive diseases, so that they hide in families.
Okay,
And
and
you
then
know,
it
if many of
just
us, you know, none of us is genetically perfect, right?
Yes.
And if many of us had full sequencing, we would discover that we're carriers for maybe a handful of diseases, right? But we don't find out about it until we have a child with someone who happens to be a carrier for the same thing, okay? So it may be that your grandparents, your great-grandparents all were carrying the one copy, which had no effect on them. And it wasn't until two people got together who happened to be a carrier for the same thing that this came to light in your family.
Okay.
So it can hide in generations with the recessive conditions. Of course, there are different types of inheritance in CDGs, but a lot of them are autosomal recessive.
Yeah.
Did I answer your question?
Yes, you did.
And then maybe you were surprised why the same mutation appears.
Yeah.
Like
Yeah.
That's why I was so.
That's,
Because it's very strange.
and they're not related.
they are unrelated, so that's unusual. We don't see many patients with the same mutation twice.
Yes.
Probably it's a milder mutation. We usually see a combination of a more severe and a milder mutation together.
Okay.
That's the general rule. Usually, two milder mutation have a better prognosis for long term. So we see that depending on the mutation, the severity of the disease is different.
Can I ask her another question? I should have asked you this. What is the ethnic background of your family and your husband's family?
Both Caucasian.
Yeah.
I don't know what.
As far as particular countries, not really.
Countries.
That's okay.
Europe from my side,
Okay.
way a long time ago.
Okay.
My husband's side.
You come from like the same like smaller town?
No.
Not really?
No.
Okay.
You should do a 23andMe. I know, I thought about that.
I'm not going to advocate that, but
I'm voting for
It will just cost you money. That's
That's
the only.
There are other
well, it's the
companies with
U.S.
better.
You know.
And all you have to do is sit it,
Everything costs money.
That's the only thing you're
Okay.
certain of.
Shoot, we have these brilliant people lined up.
Nobody had more questions? Come on, you guys were on a run.
They're hungry. No?
They have to wait.
Dinner is at 6.
Okay, so this question seems to come up, and for us anyway, like once a year, about our son's weight and whether we have to be concerned or whether it's okay because he's functioning just fine. And kind of the speed history of it all is he's doing just enough okay. He doesn't need a G-tube. Maybe he needs a G-tube. He might need a G-tube. You might want to consider getting a G. Okay, I think we're going to get him a G-tube, and then we go to the NIH. He doesn't need a G-tube. He's fine. He's got over the hump or whatever.
It seems
So we
like
get by.
when a new doctor gets introduced, they're trying.
So we get by for about a year, and then I don't know. I think we might need to consider getting a G-tube. And then we go ask another doctor. Okay, this doctor says, well, I don't know. We should really look into this. Anyway, it just never stops. So my question is, when do you get to stop and just be okay?
Are you asking me because I know you guys?
I'm asking anyone.
You're gonna back me up, right? Okay, all right. So in general, especially when you come to NIH, We look at all the growth curves, the dietitian meets with you, we look at all the macro and micronutrients, your protein levels and all that stuff. And in that minute of time, when we saw your child, things were okay. However, things happen, illnesses, growth spurts, and so really I think you need a dietitian always involved. You need to follow trends and not get worried about an individual point in time. And you need to make sure that you're doing the macro and micronutrient evaluations. And so if there is something missing, like calories or more protein or whatever, that the dietitian can add or subtract or whatever. But you're looking at trends over time, not one moment in isolation.
I agree.
I was trained by medical dietitians.
They're very good, very good. So I think the whole G-tube conversation is really difficult. I mean, we do this with all of our patients at some point or another. I feel like if, again, over time, and we probably wouldn't suggest this to you if we just saw you one time. It's really over a period of, long period of time that we would recommend that to somebody. But if you're seeing lots of different doctors at different points in time, and I understand like all these kids get intercurrent illnesses, and that's when you're gonna see like weight loss, and then maybe weight gain, weight loss, weight gain. I'm sure it's the growth curve probably looks like this, right? But the overall trend is probably going up, and that is probably what they were looking at when they looked at the whole picture and said, no, you're good. You don't need a G-tube at this point in time.
Right.
And if I remember your son correctly, he's a good eater, right? He eats really well,
He does eat
which
well.
is not common, right? That's kind of unusual, so that's a good thing.
Thank you.
Can I say two more things?
Yeah.
Yes, yeah.
Just very quickly.
You went to the bar without us?
He shocked himself.
So what I wanted to add is that actually in physical therapy, you don't have to be buffed up to go further. You can be quite skinny and develop muscles. So when you're in that phase, we are not really pushing the calories too much unless your kid is sick all the time and getting all these infections. And the other thing I wanted to say, in my experience, placing a G-tube can be really, really bad. Some of the patients just get like edema, infections. They can even go down in the course of disease because of the surgery, because of the stress, because opening up. So you only do it if you must.
Okay, yeah.
So we are very thorough before we really cut the cord.
I think, Lynn, at one point you mentioned something about the vision of CDG type 1A in terms of
The retinal
Yeah, could you
degeneration.
repeat that? What happens
So
as they get older and so forth?
right, so what it appears like right now in all of Donna's older patients that we've looked at and in our patients that we've been seeing is that somewhere in the late teens to the early 20s, the retinal degeneration just baselines. It just stops. So it doesn't get any worse like we see in some other disorders. And so and it impacts mostly night vision. So whatever is their night vision or other visual acuity issues, maybe at 25 or so, we'll see as we collect more data, if it holds up, then that's a really good thing because it means that the vision doesn't get worse and that night vision is impacted more than daytime vision in PMM2. It is progressive in some other types of CDGs that we've seen so far, but we're still collecting data, which is why I said, yes, bring your son. I need the older patients too.
Can I ask a somewhat related question? So I was going to bring it up. Here, and as far as we know with the doctors, his visibility is fine, but one of the things he has struggled with academically is his colors. And I don't know if that's a similar pattern where somehow in either the eyes or otherwise, that there's some interpretation of the colors that's not following? Is it him or is it common?
Are you colorblind?
No.
Okay, because, well, just important, because when you start to say colors, colorblindness actually is another variable to keep in mind. I have my work computer, so I can look back, but I think he actually did have some retinal changes when we saw him at NIH.
Okay.
So, but I can look at that later. So if he hasn't had a dilated eye exam lately, he probably needs one. Yeah, I do, but you data, right, open up.
Yeah.
Oh, Lynn, this is for you. You were also talking about the 8th cranial nerve.
Yes, the AVRs, yes.
Because I think I see that with Dalton.
Uh-huh. So we have to look at all of them, but we are, our audiology team actually has been out spreading the word about our AVR findings because that's never been even taught to audiologists. Most of them have done behavioral testing and or school testing has been okay. Nobody's worried about the hearing. And truthfully, how we started doing it is because if you look at any of the NGLE 1 kids, they get extremely frustrated trying to interact with language. Bad enough that they'll throw iPads across the room. So we were like, what is going on? These guys seem like they really understand what you're saying or what they want to do or what they want to express, and they can follow some simple commands. They're not getting anything out. And when we saw up to 20 of them, our oldest NGLE 1 patient is 22. And as David knows, my big boss tells jokes that can be on the edge. And our 22-year-old NGLE 1 patient cracked up laughing at one of his jokes when everybody thought, oh my God, she can't possibly even understand things. But there was a delay of like 3 or 4 minutes, and then she like really roared. So, so we went back with our audiologist to look at all of their AVRs, and then we said, oh my God, let's look at all of our CDG patients that way. And the Avr abnormalities for NGLE 1 is very dysynchronous, big, huge abnormal waveforms that move slow. Everybody else, all the other CDG types don't have that exact pattern, but the process from the cochlear through the 8th cranial nerve to the occipital lobe is extremely delayed. It's very slow. So that is something that we definitely need to use in our schools when we're talking about the children. And what it is an auditory processing defect, and that's well characterized in lots of other disorders, and schools know how to deal with it. But you need the AVR to specifically identify that that's what's going on.
And is there anything to work with, like therapies, even in like vision therapy, we do a lot.
Right.
But
So
would you
sort of
into that noise to see if you'll what to use the noise?
So you still want to encourage noise. So it's really interesting. One of the things that one of our audiologists was very excited about is all of our CDG kids love music. And so she said, you know, they may be hearing vibration or rhythm or something in a different way. And so she's encouraged a lot of music noise. We also noticed that they react differently to different tones of voice. So we have one of our patients loves his sister's voice and responds to her almost immediately, very differently than other family members. So we got service dogs. There's lots of augmentative communication devices, and there's lots of therapies that they can do for auditory processing defects. And one of the other things is that you can tell the teachers there's an auditory processing defect. So if you ask my child a question for like a test, then you need to wait. Don't like expect them to give you the answer right away. Give them some time to think about it and get the answer out and get, you know, if they can, or get them to use an iPad or some other kind of augmentative communication device. So there's lots of things that you can do, more things than I'm saying right now. But like I said, our audiologist group, we have 3 audiologists. They're so fascinated with what we're finding in ABRs and the CDG patients in general that they're out at meetings. I have a lot of their posters on my computer. They're trying to educate all of their people to start really looking for specific patterns in ABRs.
Any other questions?
So, my niece has man 1E1, and she's 3, but she's already in size 5T, and she's growing fast, and so she's kind of on the bigger scale. Do you have any specific dietary suggestions, things to avoid? Like, is there something that stimulates certain things in CDG?
So it sounds like she has a good appetite. Is she
Yes.
eating everything by mouth?
Yes, and she loves sugar.
Okay. So usually we're on the other end of the spectrum with most of the people that I've talked to is usually that they have difficulty gaining weight, difficulty eating, difficulty getting enough calories. And so for someone like this, I would just encourage a healthy, like a normal healthy diet, but with frequent meals. So, 3 meals a day and snacks, like in between. But things that, aren't as high in sugar. Healthy fats are okay. But having a balance in each of her meals and snacks. So you want to have a balance of carbohydrates, so starches, but more complex carbohydrates are always ideal. So instead of white rice, brown rice. Instead of white bread, whole grain breads. Things like that. The more the brown, grains. So combining carbohydrates with some protein, and then of course having fruits and vegetables. Does she like fruits and vegetables?
Yes.
So that's great. So the more fruits and vegetables you can give her, if you have those things in the house and have them, offered to her, and she'll pick those, that's the best way to do it. Is she able to do like physical activity, exercise?
Yeah, she walks. She's very unbalanced there, but we.
Mm-hmm. But there's things that she can do.
Yeah.
Good.
So MAN 1B1 is a CDG where 80% of the patients develop obesity, severe obesity. So in our patients, we were trying to really cut back on calories early on and start sports. Even with a normal calorie diet, you can see overweight. So you really have to put more energy in swimming or whatever harmonic sport you can imagine for her.
It's not a thyroid issue, is it?
No,
Okay.
no, it's a genetic issue. It seems like all the adults we know are overweight, and all the young adults are overweight, not obese, but overweight. So this is really a gene-specific problem.
I guess I have an opposite question, similar question, but totally opposite. For those who know, Aram is on the smaller side, and we haven't had a G-tube for him because we started early with speech therapy to help him start eating because he's a picky eater, didn't eat his vegetables. But in terms of, being small comes in handy, and some of our less supportive doctors have been telling us, well, small is good because you're going to carry him. So you want him small. We don't see those doctors anymore because we want him to grow, and we don't want him to be carried in his life. Being small lets us go to Disneyland for free because he qualifies under 2, even though he's 4 almost. But again, we rather have him be 4 and look 4, and be 5 and look 5, and be strong enough to be able to do his things. With him, we've obviously, he's taking deficiency in thyroid. My wife and I both have thyroid issues. I actually have thyroid cancer and had to be removed. We don't know if that's CDG related as a carrier or not, definitely not high cholesterol. But in terms of helping him, because we have seen several endocrinologists at Mayo Clinic, at our local hospitals and so forth, and they're still very puzzled. He has not started on growth hormone, but we went one step further and started on him with IGF-1 replacement therapy. And he showed to have grown on IGF-1. However, there were some unexplained allergic reactions, we will call those anaphylactic reactions, that we have stopped because we are afraid that those could have been related. In terms of growth hormone, in terms of endocrine, and in terms of overall hormone balance, how important is it for that balance to be in existence rather than just give him Synthroid or levothyroxine replacement to make sure that it's not just getting bigger, meaning the bone's growing, but in terms of building muscle as well as all the other connective tissue that's important for growth?
Let's answer that.
Eva, before you answer this, I have a question. You just gave me a real, no.
But they don't hear your question.
Oh, okay. Well, the question, you guys can hear the question, but the question actually was for Eva, David, everybody. Because it occurs to me, after listening to a few of you guys talk about food, and don't ask me why all of a sudden this has hit me. But in a lot of our genetic disorders and genetic syndromes, we have very specific growth curves that are normal for those conditions. And I wonder now, if we compiled all of the growth curves that we have from around the world for PMM2, if we would actually discover that there is a syndromic normal curve, and therefore we would stop making families feel like you're not doing enough to help your child grow, because as you said with the MAN1B1, we know that they tend to be overweight and it's in their genes and there's limited things that you can do, and we know PMM2 kids are very frequently little, and that's probably part of their genes. And so if we had a growth curve that was specific to the syndrome as opposed to us just saying, the 70 kilogram white man growth curve says you should be this tall at this age, maybe we really need to think about that. We could do it. We have enough data.
We do. So I think Lynn made a very good point, and I think the height is not the goal. But what you mentioned, not just the height, but developing a body structure which will be healthy and adequate. So growth hormone is not just working on your weight. It's also an anabolic hormone, so you would buff up with muscles if you have enough. Also, your blood sugar levels are better. So I think there are two issues. Do you have a growth hormone deficiency? Do you have really missing growth hormone? Then I would consider to supplement that, because that's really like thyroid deficiency, you supplement that. But just because the length is not adequate, I wouldn't use hormones for sure. Two. Okay.
Now, my question is actually along these lines, because I have a lot of families, I'm not a geneticist, I'm no expert by any means, but they talk to me about the potential of using growth hormone supplement in their kids that have CDG, and one of their concerns is that seizures is listed as a side effect. Do you have any information about the frequency of that? Because seizures are obviously an issue that they're dealing with as well.
So we've had 3 patients that have come with growth hormone already on board. One of them was PMM2 and had no problems at all. One of them, I can't remember what disorder it was, but they had much more seizures and stopped the growth hormone. But when you look at growth hormone supplementation in other disorders, the risk of seizures is actually, it's there because it has to be there, but it's quite small, and it's not generally a big issue. The bigger issue is, when is it appropriate or not appropriate to use it, and like Eva pointed out, there are some endocrinologists in the community that will use growth hormone as a management for hypoglycemia, and I think most geneticists just are like, whoa. But it can be it is anabolic, but then if you're not using all the calories that you're getting in, it can also cause physiologic stress. So I think growth hormone needs to be used judiciously, and I think growth hormone stim tests are a really good way to identify whether there's a real issue that needs to be addressed or not.
I can say something.
There's a question up there.
I'll bring it.
Lisa was on growth hormone when he was born. I think we were giving him like 3 or 4 injections a day, and because he had a deficiency. And we had an option probably 2 or 3 years ago. They told us that he was done growing because his growth plates were fused together. He went on lactose. He's almost as tall as I am.
Yeah.
He probably grew 4 inches in
He
the
grew
last
at
year.
least. Yeah. Wow.
So they wanted us to go back on growth hormone. We let him make the decision because they basically told us he was going to be a midget. He was going to have adapted apartments and everything. He was devastated. And I said, Mason, there's worse things in life. And we went home and we said, you make the decision because, injections, I think it was twice a day. And he said, I don't want to do it. I already have migraines. I already have sore hips. He said, I don't want to do it. So I said, no. And since that time, he's grown 3 or 4 inches. So I think.
Galactose.
No, but you know what this is? This is important, Eva, because, you should say this because you're the metabolic dietitian. One of the things that we see in lots of metabolic diseases, and I think in CDGs we have not considered this, but once you manage the diet well of a lot of inborn errors of metabolism, you will have incredible growth and even catch-up growth. So I'm just going to go back to, I was raised by metabolic dietitians and I work very closely with one at NIH. I've always worked closely, and I think that having a dietitian involved in your child's care can make a huge difference in their potential growth. Oops, David wants to say something too.
She agrees.
I can try again. Maybe I can add something. These are really difficult questions. I have to commend the people here trying to answer them. But specifically for the growth hormone, it's not only the hormone that is glycosylated, but probably also the receptor that is glycosylated, and that will not be normal, even if you supplement growth hormone. So the binding of the hormone to the receptor and then doing what it's supposed to do, that could still be blocked in patients with CDG. So these are really difficult decisions, and then once decided, it's not bound to work. Just as the same with the thyroid problems. We think we are doing the right thing by supplementing this in some patients and not in others, but basically we don't know.
There's a question. You want to add?
No, I also want to say that when we measure these hormones, many of the lab tests are using the glycan on the protein to measure the actual hormone. So if you have a hormone without the glycan and you measure it, you measure nothing. But maybe the hormone's there only having too little glycosylation. So maybe you shouldn't give anything because maybe with that little galactose, the glycosylation improves just 20% and that's enough to activate the hormone. While you're giving the artificial hormone, maybe you mess up the whole regulation from the brain and who knows what you are doing. So measurement can be absolutely skewed.
I know you had talked about nutrition for the older children, but for the little children that we're trying to get from a bottle to try to more foods, but he won't open his mouth. That's part of the problem. What are some things that are more important to you? Some more foods that are a little bit more important to focus on than others.
So the first thing I would suggest, do you have a speech or occupational therapist?
Yes, we work with 2 different.
Okay, good. That's what everybody needs. That's like the most important thing because they can really help because I know a lot of these kids have texture aversion, taste aversions, lots of different combinations of things, and so having someone who can work with you and give you ideas of, because of course you're going to be with him every single day, give you ideas of how to work with things. As far as food, so has he tried anything?
Yeah, he's done pretty much everything.
Okay.
He was doing better, and then he got sick. And when we saw him kind of go back a little bit on the foods, now he won't open his mouth at all.
Okay.
He will, for some things we've done, like the Nook, we've done some vibrations once we've seen, like, once what they observed at the... Yes, I agree. What they observed was that once he realized he liked it, that he did better with opening his mouth and then taking more food, but he was really hesitant to say, I don't want to open my mouth for that because I don't know if I'm going to like it or not.
Right, and yeah, definitely after an illness, especially if it has to do with vomiting or coughing or anything where it's, in your mouth and your throat, that can make a big setback. So just give it time, and be patient, and it will come back. But just even putting the things that you remember that he liked, like just putting them on his mouth, or just giving him a little bit of that taste, and that might help to have him open his mouth.
Like he likes peaches, and he does pretty good with like some oatmeals, or rice cereal, those sort of things we have decent luck with. But right now he pretty much is just on Pediasure. I have a hard time getting him to drink water even.
Yeah. So he's getting his nutrition from the Pediasure, so don't stress about like worrying. I know, because it's a constant worry and struggle for all these parents to be worrying that you're not getting enough into your child, and I know that's a stressor, and when the parents are stressed, that can make the kids stressed. And that can even add to just the issue of them wanting to eat. So relax, and knowing that he's getting what he needs from the formula, from the Pediasure, and just try to get him to taste things. If he doesn't eat it or he doesn't eat it all, don't worry. If he's getting the formula or Pediasure that he's getting the nutrition he needs, but just think about it as him learning to eat, him experimenting with tastes and textures and things like that.
Is it okay to would you say yes or no to putting like apple juice in with the water just for a flavor to get him to drink? Because
you could.
When we switched over from formula, there's a little less of the liquids that he would have been getting, so they wanted to make sure he's still getting those.
Enough, right.
But I can't get even that extra ounce in. So.
Yeah, you can mix like a fruit juice with water or something like that. Just it's not so much, sugar from the juice, but you can mix it just to give it a little flavor. That's fine.
I was wondering with type 1A, is there, in addition to being small, is there sort of a different type of growth pattern in terms of looking older? My son's 29, but if you were to look at him, you would say he was 10, or he's discovered the fountain of youth or something. He doesn't look his age. You don't have to. You have to shave him. His brother, 4 years older, is part bald. I'm just wondering if there's some kind of like, is he still growing? Is he whatever?
You mean aging?
Yeah.
So many times we see that the hormones which make us real like adults, they are not high enough. So the male hormones, for example, but females also have lower hormone levels and they don't mature. And that has an effect on how you look. So it's measurable, very easily measurable in your son. You can measure the hormones which are regulating the development from the brain, but also measure testosterone and see whether it has a hormonal background.
Yeah, no one's ever brought up growth hormone at all, ever. But he's small, but he can still, get in places for free.
Under 12.
Under 12, and he's 29.
So I think an endocrine evaluation would be really smart in him, although I would be very cautious about hormone supplements, because when we give supplements patients were not getting all along their maturation. If you just overload the body with those unknown hormones that can have like a very abrupt effect, they could go in an abrupt puberty, which could really make the disease more severe. Behavior abnormalities, temperament problems. We see many times when we start to supplement hormones like female or male hormones too late, then it has negative consequences instead of positive. In females, we usually do supplement the hormones because for the bone density, it's important to have the female hormones. In males, it's really depending on do they have any problems missing testosterone. You know, it's not really a health issue mostly. So you would think twice before you treat an adult patient who never had enough testosterone with the dose.
It will just give you problems.
Good summary.
In other words, we just agree with what Eva just
Yeah.
said.
Male
What is the, I have a question about seizures. My son's seizures are currently under control with his medication. So is that something that will stick around with him forever if there, I mean, any chance to ever get off? What is the trend seem to be with that, or is it all just trial and error? I don't know, keto diet, I know I've heard can help, but I don't know, you know, long term.
We are fighting for the microphone.
No.
Just him.
I think we can just give general answers. If the seizures are controlled, well controlled for more than 6 months to a year, you can always try to go down with the medication, go from 3 to 2 or to 1. And if that is still well controlled, then you can try to get them off the medications. In the adult patients, you don't often see that the seizure frequency is going up. So you can try. It's trial and error, absolutely. And so there are rules, and epileptologists will know the rules, and they will tell you which medication to stop first.
So in my practice, I see much more improvement in seizure in those patients who have controllable seizures. And there is a group where you cannot control the seizures and you try drug 1, 2, 3, ketogenic diet, brain stimulation. Those patients could get worse with time. But the well-controlled seizures are usually benign, and many patients grew them out. In AUDGE 13, the female patient Lynn was mentioning, they have horrible seizures. They continuously seizing, and you cannot do anything about it. But I think in his case, he reacted just fine when he was started on medication. So I would estimate a really good prognosis in his case.
Any other questions? I have a question. Dr. Marva, you mentioned about specifically hormone testing being glycosylated, or the tests themselves rely on the glycosylation to measure the number of proteins present. Yet, if the child has glycosylation disorder, it may be thrown off. We mentioned this to our endocrinologist, and they seem to be a little bit puzzled about how they're tested. You have a knowledge of specific tests, and there might be several ways of testing, let's say free T4, free T3, TSH, and growth hormone, IGF-1, and so forth. Of where should we go, and how do we talk to our doctor, endocrinologist specifically, on which tests to take and which tests to not take regarding hormones and specifically endocrinology.
Eva, can I take this one first?
Yes.
Because you're on the way to NIH.
Yes.
So we have an endocrinologist, Konstantin Stratakis, who has worked with Donna Krasnovich for 30 years. So he actually, in his lab, looks at the glycosylation patterns of hormones. And in fact, we had one of our female patients was very, very delayed in puberty. And he has somebody in his lab that studies just follicle stimulating hormone ovules. But so we have lots of resource there. But he and Brad Miller, if you've never talked to Brad Miller, he worked with Constantine early on, and they actually have a pattern in the hormones that they see in CDG patients that they don't see in other patients. So when you're at NIH and Constantine comes to talk to you and looks at the hormone levels, you say, Lynn said you can tell if this is a CDG patient and have him tell you what he sees. Because he actually has told all of us. But I think you have to have an endocrinologist who's looked at multiple CDG patients and knows what is hypoglycosylated, and even more than that, what's N-linked, what's O-linked, what's mixed in those hormones and those receptors. And then like Eva said earlier, for both hormones and the immunoglobulins, sometimes the hypoglycosylated proteins are there and they're doing their job fine. They just have a shorter half-life than what you or I might have, and that can skew what you look at. So instead of looking at a level, you look at the whole pattern.